one thing I really valued is learning how to do a team science approach. And what that means is that you get people that have backgrounds, different areas of interest. And between kind of that active conversation, I think that's really where a lot of ideas get generated. And oftentimes it helps when you have multidisciplinary team, you really kind of leverage the strengths of each of those individuals. And so that truly is kind of what I find most fun about team science.
Welcome to the Veterinary Cancer Pioneers Podcast, the show where we delve into groundbreaking work of veterinary professionals who are dedicated to advancing the field of veterinary oncology. I'm your host, Dr. Rachel Venable, and I'm thrilled to embark on this journey with you. Welcome to the Veterinary Cancer Pioneers Podcast. I'm your host, Dr. Rachel Venable, and I am so excited today. We have Dr. Joelle Fenger, and we are going to learn more about what she does with Ethos and her career and comparative medicine and some clinical trials. And her background is really interesting. She's a medical oncologist, cancer biologist, and advanced training in comparative clinical trials. She completed her veterinary degree at the University of California, Davis, did a rotating internship and an oncology residency with a PhD. Quite impressed. I definitely did not do the PhD. In comparative and veterinary medicine at Ohio State. She was faculty at Ohio State before joining Ethos and then Ethos Discovery in 2021. So her expertise is in comparative oncology and extending early preclinical findings into translational applications. So that's the stuff I really love. I love comparative oncology, and we'll look more at the studies and things she's doing. So Dr. Fenger, thank you so much for being on the podcast with us today.
Well, thank you so much. I really appreciate the opportunity to speak with you and get engaged in the veterinary community, and just really pleased and grateful to have the opportunity.
Well, thank you. And, something I always like to know, and just kind of getting to know someone a little bit better, is what got you into oncology? And I feel like this is what people ask me all the time when they find out you're an oncologist. So how about you? What got you into oncology?
Yeah, well, I'm probably one of the rarer people in that I didn't know that I wanted to be a veterinarian when I was a kid. It was actually something that I kind of fell into a little bit later. When I think back, when I was a kid, I was going to be a journalist. And then when I was in high school, I actually played the flute and was going to be a flautist. And, life happens and didn't get into music school. And ultimately ended up studying at the University of California, San Diego, which, aside from being a obviously beautiful location, was a really great sounding board for me to just sort of be an undeclared college student. And there, I really was just thrilled and curious about really the science that was going on that campus. And, I was really lucky to kind of go into more of a comparative animal physiology sort of a training program. Spent some time at the Scripps Institute of Oceanography, and that really kind of like tickled my curiosity as far as just science, and then medicine. And really that was the basis of like comparative medicine for me. And what I will say is that really led to me kind of getting interested in the veterinary field and comparative medicine. And so that's sort of fast forward how I ended up in veterinary school. With respect to specializing in oncology, it really came from a personal space for me. So when I was 23, my father was diagnosed with prostatic cancer. Ultimately, he also developed colorectal cancer. And so I will say that I was in my 20s, you're pretty young, and honestly, being on the other side, being on the patient and family side, really influenced sort of my understanding, like as being a patient and family member on the other side. I was curious to kind of understand like the science and then the medicine and the biology that was going on. And then also just really come to recognize just the field of oncology and how much of a special field it is. And that goes from everything from not just the fact that there's really new and innovative and really cool scientific stuff going on, but at the same time, there's so much more than that. And really like the survivorship piece and the family piece, and truly like the journey going through anyone who's being treated with cancer is really what kind of like my experience. It was just something where I was kind of like, well, I get this. This is tough. I would love to be on the other side of it where I could actually be helping patients with cancer. And so, sadly, my father passed away in 2010, but, he was really great. And seeing that cancer journey, I think we all know it. And now that I'm a veterinary oncologist, I see it in my patients. There are good days, there are not so good days. You have to think about survivorship and hope and kind of look out for new cures. It's tough. It's a long battle and it can go up and down. And so, I think that personal experience ultimately combined with just my curiosity about science was really what drove me into that field. I can't say that I'm here without the help and support of like some really phenomenal mentors, many of which we know in the veterinary oncology field. When I was a veterinary student at University of California, Davis, I did a summer research project with Cheryl London and literally did like 80,000 Western blots, none of which worked. And so, got to present my like 12 slides of completely negative data, but it was a really great experience. And obviously, she's a real pioneer in the field of oncology. I learned so much, and I to this day consider her a friend first, a colleague after that. But really, it was phenomenal working with her, and obviously, really kind of stimulated my curiosity. This was the days of the early Palladia field trials, and seeing her enthusiasm about like, wow, this is like actually working, and then understanding in the lab setting like why this was working was really exciting. And so, fast forward when I had done my internship and residency at Ohio State University, Cheryl was also there as faculty. That's where I had the opportunity to delve into the science part a little bit more. And I did my PhD with both Cheryl London and Dr. William Kisseberth, and really benefited from just the phenomenal mentorship that they started the spark. I'm really grateful for that. That's really, how I delved into where I'm at now. One thing I did do is I had the opportunity to stay on as a research intensive faculty member at Ohio State University. And that was phenomenal. The Ohio State University is a really huge campus. They have a world-renowned James Cancer Center. So one thing that I really had the opportunity to see there and that I really loved in the academic setting was learning more about team science. And so, cancer is incredibly complicated. One brain is not going to fix the problem. And so one thing I really valued is learning how to do a team science approach. And what that means is that you kind of get people that have backgrounds. Sometimes they're quite different and surprisingly different areas of interest. But, you can get a bioinformatician together with a genomic scientist, with a pediatric oncologist, and then bring in a veterinarian who also treats, tumors that are similar in the pediatric setting. And between kind of that active conversation, I think that's really where a lot of ideas get generated. And oftentimes it helps when you have multidisciplinary team, you really kind of leverage the strengths of each of those individuals. And so that truly is kind of what I find most fun about team science. And honestly, when I had joined Ethos Veterinary Medicine, again, speaking about mentors, I was really lucky to work with Chan Khanna, who's wonderful and obviously another pioneer in our field. And really, my discussions with him were that I want to, it's time for me just kind of as a personal for me to try something different. Still wanted to do research, but maybe not necessarily in like an academic environment. And so that's kind of what led to us discussing about opportunities with Ethos Veterinary Health and then Ethos Discovery. So Ethos Discovery is a not-for-profit research, really an incubator of scientific research. And we work closely with the Ethos Veterinary Hospitals. And so the Ethos Veterinary Hospital Network is now a network of over 145 specialty and emergency hospitals. Within that, there's a little over 70 oncologists. And these are, oncologists that are spread all throughout the United States and Canada. And so I honestly wasn't very clear about, can I continue to do research? Can I still see patients and do that in kind of a new bubble? And so, I think working with Ethos Discovery and Ethos Vet Health has been really innovative and kind of rejuvenated me a bit from the standpoint that I am able to kind of wear a couple of different hats. And so, I do see patients as a medical oncologist, and then I have an opportunity to also help manage write up and kind of analyze all that like real nerdy data on kind of the ethos discovery side. But again, within the context of a little different from academia, but also very parallel in some ways, in that there's sort of multiple sites or multi-institutional, multiple investigators leading these trials across a wide variety of geographies, which is probably important. Our goal is that we can kind of do this and hopefully, be able to actually accomplish goals of kind of high evidence-based prospective clinical trials. But really, it's just in a private practice setting. So that being said, we're very agnostic to who we work with. And so who do we work with? Ethos Discovery, the boots on the ground is sort of clinician scientists like myself. Obviously, I spend some time in the clinic. I can be involved in clinical trials and seeing those patients. And then kind of on the flip side, be kind of on the scientific side where we can help with the design of trials, analyze that data, talk about disseminating those findings within like the scientific community. But it goes back to who our collaborators are. And so it's been really fun in the sense that we've gotten a chance to collaborate with industry partners and academic partners. So again, I hope to see this kind of a model be a little bit of a bridge between the ways that you can do team science. And so that part is again, that's what I loved when I was in academia is team science. Love that I'm able to find that kind of an opportunity, but just in a little bit of a different environment.
Yeah, I think that so many important points, covered there and loved all the different stories and everything. And I am interested, because ethos, like you said, it's private practice, it's different. How would you compare it to academic science? Like, are you still able, because like the team, is it more narrowed with ethos? Because I would assume in academia, especially like Ohio, like you said, you had access to all these various fields and different things. So how would you compare and contrast the two?
Yeah, I think it's a really good question. And obviously the academic model is one that there's a huge opportunity to have all sorts of different multidisciplinary teams. That's something that will always be phenomenal and hard to recreate in any other setting beyond a really large university setting, if you will, or college setting. On the flip side, so when we talk about being clinician scientists in sort of a private practice infrastructure, one thing, there are some important differences. So, what we don't have with Ethos Discovery is a true wet lab. So, because of that, and I don't necessarily think it's a barrier, but our partners, or whether that be industry partners, it could be actually academic partners, those are the individuals that are actually able to have like the wet lab, capabilities to do, what someone said, like the science part of it. Obviously, what we have, and we have tons of them, is hospitals where you can actually conduct, and you're seeing really high volumes of patients. The clinic load is really quite heavy in private practice. That being said, the patients that we're serving, the patients as well as their families are interested in exploring things like clinical trials. And that can be a little daunting. There's only so many veterinary schools, and like everything, there's access, geographic access to be able to actually be part of or have your own pet participate in some of these really innovative trials has always been a barrier, right? And so I would say that from the context of doing these trials within kind of the Ethos Veterinary Health Network, the ultimate goal would be you could open a trial at each of those hospitals. Then it actually allows our pet owners to have accessibility to medical care, and hopefully it would be innovative, cutting edge trials that they can actually have access to. So, again, I think one important difference is that the scope and the scale of the geographic encatchment of sort of a private practice setting is really beneficial from the standpoint that hopefully it could provide access to pet owners that otherwise wouldn't have that. Those are going to be, the very big differences, and recognizing those differences, it just sort of means it's a little bit nuanced in terms of where you're actually conducting your work. In many cases, again, the wet lab being an industry partner, academic partner, biopharma. What we our laboratory, if you will, is really going to be on the clinic floor. So that's my new laboratory is, being in a clinical hospital setting and being involved in the collection of clinical biospecimens, if you will.
Yeah, and I think it's great because, like you said, there's, roughly 70 oncologists. I mean, that's so much more than most, academia. So I think it is cool. And also, you guys can work with academia, so
Yeah.
hopefully we'll get those trials that have more dogs. I always think it's tough, but I still practice a lot of medicine off cases where, studies that maybe had 20 dogs, right? 30 dogs. And so this big network, I think that will be great, and you guys have already ran studies. What's something that you guys are doing now that you're really interested in?
Yeah, there's always the question of like, so how do you prioritize projects? How are you even picking these projects? When you're in sort of an academic university, oftentimes laboratory programs will sort of have a specific, a theme or a niche that they're really into. Whereas that kind of dictates sort of where their grants are going to be, where their projects are going to be, where the focus of their laboratory is really over like a 10, 20 years time span. When we had created Ethos Discovery, and sort of knowing that it was within the context of sort of a private practice network, one of the things that we really wanted to do was identify scientific priorities that were really answering questions, concerns, griefs and gripes that clinicians that are like the boots on the floor, that they were actually in need of. So what we often will do in order to really sort of, we will query our clinicians and we ask them about what are the unmet needs that you have. You have a patient in the hospital today. And like, what is the frustration or unmet need that you would like to have evidence-based medicine or evidence to support your practice of medicine for your patient today? And so that has really, that served as a sounding board for us to kind of see, so what is it that the clinicians, our stakeholders, are asking for? What would help benefit from them? And then what we do is that on the Ethos Discovery side, I mean, and again, it's a bunch of clinician scientists. We have meetings, we go through what are the unmet needs that have been identified by our colleagues. And then, we're the group that can kind of say, hey, well, let's try to see what industry partners are out there that might be able to help answer some of these questions that you have. And then how can we design a prospective clinical trial to help answer those questions so that ultimately the end goal would be that can we make some discoveries that would ultimately help you in your practice of medicine with that patient in front of you today. So that kind of goes back to how our, priorities have, or at least our scientific portfolio, has kind of emerged from. One of the first programs that, when we asked clinicians what an unmet need was, and this was, you could ask a surgeon, an emergency clinician, an oncologist. We all hate hemangiosarcoma. It's a crummy disease. And all of us, we see it, and the owners ask us a lot of information. Oftentimes, kind of have these responses where you're like, that's a really great question. Unfortunately, like we don't really know that. And I can't really advise you one way or another. Particularly for emergency clinicians, presenting with a dog with a chemoabdomen and like a splenic mass, talking to owners about, do you want to embark on what is going to be a lengthy, a costly, treatment protocol with a lot of unanswered, a lot of unknowns before you even go to surgery. And so that was really where we had launched. It's called the Ethos Push study. It's the Ethos Precision Medicine umbrella study for dogs with hemangiosarcoma. We use lots of acronyms, but Ethos Push is the hemangiosarcoma study. And that's really asking some of these just basic questions that an ER clinician would like to know, which is, geez, how do I differentiate between whether or not this is a benign splenic mass that bled that maybe you'll live with after surgery versus a completely and entirely different kind of conversation? Is this going to be a very aggressive cancer that, yes, we have treatments for, however, your pet will succumb from this? Sort of taking a step back and saying, when we all trained in our residencies, we largely read retrospective studies. And we know now, our practice has changed, histopathology has changed, so much has changed. And so I think there is some value in trying to see a little bit more of like, all right, nowadays, what is this disease looking like? In that study, one of the first things that we were just looking at was, so what is like the incidence of benign versus splenic pathologies in dogs that are presenting with a hemoabdomen and a bleeding, splenic mass? There's that thirds rule that, 2/3 of those are going to be cancer, 2/3 of those are going to be hemangiosarcoma. And we kind of say it, but we don't really know if there's evidence to support that. And so one of the like important findings that just kind of came out of actually saying, all right, well, we're going to get these dogs to surgery and start doing pathology and actually determine like what is the incidence of benign versus splenic pathologies. And And again, if you look at the retrospective literature, they're usually pathology papers, but they can report anywhere up to 75 to like 96% of those tumors will be malignant. And so in our, at least in a specialty and emergency practice setting, data so far, and we've now enrolled and screened 407 dogs across like a multi-institutional nationwide prospective trial. And the data keeps coming back that really the incidence of benign splenic pathology is probably about 40%. That means that 40% of those dogs that are presenting to you, could actually have a really great prognosis and potentially a disease that it's benign nodular hyperplasia and they may not die from that. And so I think it's a real game changer. And so, that's just an example of sort of some of the prospective data that we can get out of that. The more scientifically nerdy questions that, are attempting to answer as well in a prospective fashion would be related to answers about, the genetics and epigenetics of this tumor type. So simply looking at a defined tumor histology and kind of understanding sort of molecular alterations that we may ultimately identify. And that might be related to prognosis and might be something where we could view it as a therapeutic vulnerability. Again, I think all this information is just good prospective information for us to know. And beyond that, because we, have been collecting, tumor tissue, blood samples from these dogs, I think there's a whole slew of questions that we can be asking related to what they're kind of looking at on the human side, obviously, which is, things like circulating tumor cells, is there non-invasive ways for us to detect, either tumor mutations, tumor burden, if you don't have access to maybe a radiologist to be doing all of your ultrasounds, is there a way to sort of monitor our patients that might be appropriate alternatives? We have to answer that question about whether, what's the most appropriate. But I think there's a lot of avenues that we can look at. And again, these are patients that are with the help of the PUSH trial. These are patients that in some cases wouldn't have access to what can be like a ultimately a $12,000 to $15,000 bill in a private practice setting to kind of get through emergency splenectomy, recovery. Then they're starting on chemotherapy after that. It's a huge effort. It's no feat that it's truly, all the oncologists and clinicians that are working doing this. This is their day to day, but they truly are really helping pave progress for the future of our field. It's important to recognize, but it takes a really long time. It's baby steps, but I think that we should be really hopeful that there are some more hopeful messages that are emerging. Again, it's like 40% of them will have benign, splenic pathologies in at least in the emergency and specialty medicine practice setting. Most of these dogs undergoing splenectomies, post-operative recovery are getting discharged out of the hospital in like 48 hours. So we kind of, again, even just from a surgeon perspective, knowing and being able to counsel owners about what to expect post-operatively, what the recovery is like, all of this, it's more contemporaneous information now that the field has totally changed and expanded and specialized. And so I think this is really great data for us to be able to share with owners because they're the ones that really need to use this information to make the best decisions on behalf of their fur family.
Well, there's so much we don't know about hemangiosarcoma or really haven't moved the needle a whole lot, right, in the last few decades. So I'm certainly excited and encouraged at what you guys are finding and what more, questions you guys can answer. So I think that's fantastic. And I love how you approach it all from the real, like, what are the pain points in the clinic? I'm sure with research, sometimes it's easy to get so specialized that you kind of go down a rabbit hole that maybe doesn't in the real world help so much.
Yeah.
Or,
Yep, yep. Yep. It's not uncommon for folks to sort of, study a gene for, 20 years. And it's been fun to kind of get back in the clinic and then kind of get back to, or again, based on what my experience was being on the other side and receiving information about a cancer diagnosis and, recurrence and all that stuff. It's kind of nice. I always say that I go to the clinic, my laboratory, I see patients, and then I'm like, man, this is a crummy disease. I got to get working on, on that. So it stimulates you to really like want to keep going and learning more and advocating for your patients.
right. It gives you that drive to really just keep going, which is fantastic. And as you mentioned, you guys like acronyms over there. And I've heard that you are starting a new trial called Solid and working with Imprimed on this. Can you tell me a little bit about what Solid stands for if you have it memorized? And what exactly are you guys doing in that trial?
Yeah, and I am a employee of Ethos Veterinary Health. I work with Ethos Discovery. We actually don't receive any funding from Impromed for this. However, they are a collaborator on this upcoming SOLID clinical trial. That being said, so SOLID is actually an acronym for Stratified Outcomes for Lymphoma in Dogs. And so it's a real, mouthful, but don't have to tell anyone in the oncology community today that, everyone believes that, while we talk about lymphoma, we'll like maybe say it's T cell, B cell, large cell, intermediate cell, small cell. We know that there's at least like 25 different subtypes of lymphoma. And, while we know that, and that could be on a molecular basis, it could be on basically the phenotypic features of these lymphomas, if you will, from a flow cytometry standpoint and IHC standpoint. But we oftentimes you have not nuanced our treatment plans, despite knowing that there are different flavors of lymphoma, as well as, we just don't know potentially if some types of those lymphomas may respond better to other therapies or not. And kind of the current state of treatment for dogs with lymphoma and cats with lymphoma, I mean, it's certainly come a long way, which is already exciting. But oftentimes when we sort of want to give owners information to help them make decisions regarding their pet's care, some of the questions that they'll usually ask is, what's the outcome? What should we treat with? There's always that. I always say, I forgot my magic crystal ball today, but the average survival times are going to be here. I hope that your pet is on that upper end, but you just be prepared that it could go anyway. It's really tough. It's really tough to kind of break that news to people. But we've certainly had a lot of advancements in, number one, the degree of histopathologists or pathologists that have a special interest in lymphoma. In addition, some of the histologic markers that they can use to help kind of actually tell us a little bit more about what subtype of lymphoma that is. Even better yet, when we can take live cells from a patient and we can do flow cytometry on it, on those samples, that information can help us tell us kind of the phenotype of that cell and then help maybe predict the behavior and responsiveness of that tumor. And then obviously there's really like new and emerging technologies, which are the really exciting part, and that goes anywhere from sort of more deep sequencing to understand kind of what is the genetic basis of lymphoma, all the way to, again, in relation to Impromed, is actually taking cells from the patient and then incubating them in a tissue culture dish, kind of a fake patient, if you will, and then applying the drugs that we're using to give the clinician a bit of an idea about, how responsive we predict those cells or those lymphoma cells to be. And so, again, these are like the newer tools that are out there. The question is, again, back to the clinician, is how do I use these tools? What patients is this best? Should I be using this in? And then really, like, what do I do with that data? It's always the tough part. And so with the solid lymphoma trial, again, this is sort of looking at going to be various types of lymphoma, but we are specifically looking at the higher grade lymphomas, nodal lymphomas. And essentially, we are starting from what we're doing now. So what we currently treat most of our patients with are usually going to be multi-agent or CHOP chemotherapy protocols. And so, again, where we're starting with this trial is prospectively looking at kind of our current state of lymphoma treatment in dogs, with the idea that when you kind of use and hopefully being able to look at all of these things, whether that's flow cytometry, histopathological information, looking at other assays like the Impromed in vitro assays, and then looking at their use of AI predicted cell sensitivities and blood-based biomarkers. These are all things that specimens that we will be collecting in a prospective fashion in dogs, with high-grade lymphoma, both T and B cells, in our current standard of care, which would be kind of CHOP, if you will. And so again, what I will say is that there's not necessarily a new therapeutic arm that we're offering in this trial, but the goal of this trial is really kind of a discovery trial, is that can we actually start taking specimens from these patients and then actually using a multitude of different assays, diagnostics to understand more about really like the utility, and then in a more prospective fashion, understanding where we use these diagnostics, how can they help us? And then, I think because we know that science is really complicated, and oftentimes we always say, well, it's very multifactorial. There's a bunch of different things that are going to contribute to this. That's kind of where I would get really excited, honestly, about some of these more AI-driven algorithms, because our brains, unless you're a biostatistician or a bioinformatics person, they know how to crunch a lot of really big data sets. But that's where I actually am really excited about, like learning about the role of AI. I mean, you can go into your TikTok account right now and spend 15 minutes on it. And then based on how long you look at something, whether or not you paused it, it will track all of that data. And then it will basically, curate like Joelle featured TikTok, which you don't never want to know about. But again, that's like kind of the interesting thing about AI is that can you actually use these training algorithms to start looking at just a multitude of factors? Because I think it's going to be really, really complicated. You could look at the phenotype of a cell on flow cytometry, and then what if that doesn't match up with like the clinical expectation of how you thought that patient was going to do? But maybe there was a biomarker in the blood that could better inform you. So these are sort of the hypotheses that you'd be testing in that setting. And again, I think it is something where, a lot of these patients are getting treated with CHOP to begin with. I think it's a great opportunity for oncologists that are in private practice to kind of get engaged in like a prospective clinical trial, with the idea that we might not have a new therapeutic right now, but the goal of this would be to kind of discover new findings and then kind of iteratively build upon that to start adding to the backbone or modifying things, and ultimately figuring out if we can kind of improve not just diagnostics, but ultimately therapeutics and then outcomes. That would be the really, celebratory goal for sure. I'm very excited about it. I think that, again, Imprimed is going to be a collaborator with us. They've shown some really compelling data that has, suggested that not only just the in vitro predictive responses of these cells, the question that we, hopefully would be trying to answer is, how does that relate to the patient that you're seeing right now? But I think one thing that's really, cool and intriguing about it is really utilizing AI-driven algorithms in order to kind of start processing a lot of these data variables. And so again, my brain's too small to kind of do that, but I'm really excited about having a possible mechanism, and AI is here. And so I think if there's a way that we can actually use it and integrate it into the management of our patients, I mean, I'm all for that. So I'm excited to see. It's fun to change your practice of medicine. And so the other thing that is really nice about a trial like this is that, again, back to being a practitioner in a hospital, is that a lot of tools come out and you can sit in a lot of CE and meetings, but honestly, if you don't have a chance to really use them in your day-to-day setting, it's very hard to change and like start running new tests and learning how to bill them and what samples to collect. And so honestly, as a clinician, I really enjoy when I get to like run a new diagnostic just so that I can kind of get a hands-on experience and kind of get myself used to changing the way I practice. So specific phenotype of clinicians that want to do these trials. But if you're curious, it's a great way to hopefully gain new knowledge for our patients.
Well, I love it because you got to keep growing, right? Because I would say lymphoma, that is one of the spiels that I could probably do in my sleep, because we haven't changed it a whole lot. But we all have had cases where it's like, well, everything on flow said this should have gone great and it didn't, or
Yeah.
everything on flow said this should have gone terrible, but it actually did it, and I think what you guys are doing, hopefully, like you said, we'll get, because we know there's more types of lymphoma, and if we could figure out more detail on this is what actually makes a difference, or this, really tease it out. And I agree with you too. I certainly don't want to crunch all those numbers. I think AI, it makes sense because then we can look at such bigger data sets than we could before, and
Right.
that is really exciting. And I'm with you. I think you have to keep pushing for more, pushing for better, because frankly, I feel like that's culturally what our society does. If I think about when I was a kid, so much has changed. And so, medicine, we want it to get better, right? We want to do more. So we also, you can't get lazy and get stuck. You got to keep pushing the needle.
Yeah, absolutely. And again, it's the practice of medicine. So, you can practice a whole different bunch of ways. And I hope to see it, I hope to evolve, as a clinician and not be doing the same thing that, that's usually what drives most people. But kind of back to the idea of, what's the value of doing a prospective clinical trial, maybe not for like a novel therapeutic. I do think that within the context of lymphoma, the one thing would be that if we can actually have a multitude of variables to look at. So there might be a bunch of variables as far as like the assay that's being performed, but then what's important, and at least, kind of what we would be doing as with respect to running these trials through Ethos Veterinary Hospitals would be the idea that we can at least have a patient population that is fully credentialed. And that can be, again, on like molecular basis, physical exam findings, back to, there's a subset of dogs that are basically going to progress during CHOP and become, chemotherapy resistant lymphomas. And so even understanding, is there anything that we could do to actually identify those patients? And we might not too. You have to go into every day in whether it's the clinic or a research base, research laboratory, you have to be okay with negative data. It's not necessarily failure. I think that sometimes it's just really good to know that, like, nope, this isn't worth looking at. And so it can be quite daunting. We all get a little bit discouraged by that. But I would say, that sometimes those negative findings are still important, especially because the ultimate goal would be, could you deliver some information that could help the oncologist that has a patient right in front of them that day? And so like the genomic studies take a really long time to do. This is really complicated stuff. This is not for, faint of the heart. But I do think that there are some smaller questions that hopefully we could identify or answer a little bit quicker as all of that other genomic information is really moving forward. So hopefully, one trial can serve as a basis to answer a number of questions. It just sort of depends on what question you want to ask.
Right. Yeah. Research, that I think that's the tough side, right? When things aren't working, or at least like they're not answering your hypothesis, but it's still such important information. I totally agree. And I've definitely done the Western blots that didn't work. Yes, I had that experience in vet school as well.
And I actually, to your point, what is really, really challenging is that not every veterinary training program or oncology residency program has exposure to kind of the more basic sciences. Obviously we all had to do a bit of research when we were kind of getting our paper requirements done. And unfortunately, because it's such a high pressure, high volume pressure cooker when you're in a residency program, I'm not surprised that most people do come away with like a very bad feeling in their gut whenever they think of research. I would love it as, someone at Ethos Discovery and Ethos Vet Health, if I could actually work with a house officer and then convince them that like it's not that bad. Or even better yet, if there's someone, an oncologist that I talk to that's like, oh gosh, that's bringing up all these bad nightmares of my experience. I would love it if we could make it not so scary and not such a bad experience. I don't want everyone to like relive their trauma, but I really hope that we can relive it and they can actually say, like, you know what, as a clinician scientist, you can do work, you can do clinical research. I have a PhD and it certainly led to sort of my understanding of comparative medicine and got me here and helped me understand a bit more of the cancer biology part of it. But I think that there is all of us, even just as a clinician, you're literally looking at data every day and then processing it in a really rapid fashion, probably in a 30-minute, chemo recheck, and then actually coming up with a diagnostic plan. And so we're actually crunching all that data in our heads. So everyone can be a clinician scientist. It's just different levels of it. And honestly, it goes back to like how curious you are. So I hope to like change people's perception if they had a really horrible traumatic experience when they did their residency program. But what I will say is that I also can't generate their scientific curiosity. All I can hope is just inspire people to be like, wow, seems like this gene is really interesting, So, but the curiosity is kind of there, like, got to be inherent in you.
And I feel like the curiosity, if you just think about what you said earlier on, what are your pain points? What questions do you need answered? That's really starting research right there. So maybe people are more scientists than they think. I agree with you. I hope people, as veterinarians, we had to do so much science, and you really are a scientist because, like you said, you're going through so much data, whether you realize it in the moment, you really are thinking all these things through. So I love that. That's great. And I agree with you. I hope people can embrace some of the research and maybe not the bad experience. Hopefully they didn't have one, but if they did.
Yes, yes. There is some nice trials that hopefully pique someone's scientific curiosity and at the same time provide them access to care or a new drug or a new device for their patients that they wouldn't have otherwise. So I feel it's a win-win, but I understand it's daunting.
But it's the way we move the needle forward. So, and I think it's so exciting to hear the different things that you guys are doing and how many different hospitals and geographically, because I agree with you. I think sometimes geography plays a role. So I think that's really interesting. You guys are able to tap into different areas. And, this has been such a great conversation. And as we're wrapping up here, I always like to ask, who else would you recommend as a guest on this show?
Yeah, I love this question because honestly, there are so many wonderful and pioneering people in our field. One thing that I am incredibly excited about is like the younger generation of clinician scientists. Like they're the future. It would pain me to sort of see the work that we've done just sort of stall out, which I know it won't. But in that case, I think that really love to give props to some of the emerging stars and current stars in our field. And people to watch would be, I would say that from the standpoint of cancer genetics, Dr. Heather Gardner and Katie Maguire at Tufts University are really truly leading this field. That is no small feat, doing bioinformatics and understanding the genomic technology, which is truly changing on like a every 6-month basis. And so they really, I think, are the real emerging experts in the field and have worked really closely with Dr. Amy LeBlanc at the NCI. And so I can't wait to see what they're doing. Additionally, two other friends and colleagues of mine that I've had an opportunity to work with through Ethos Discovery are Doctors Jacob Colley and Dr. Sridhar Velvelu. And they are both doing postdoctoral fellowships in actually human cancer laboratories or human biology laboratories. And so again, they're in really well-established laboratories. I think that they're getting like kind of a phenomenal postdoctoral experience, but all at the same time, those are the folks that are really going to be advocating for the inclusion of veterinary oncologists and, comparative medicine specialists in kind of driving the field. And so they're doing a bit more molecular work kind of in the field of osteosarcoma and hemangiosarcoma. But I'm really excited to sort of see what they're doing. And, I love hearing the science from them because that's the stuff I love nerding out on. So all of those young pioneers are going to truly change. They're going to change the face of veterinary medicine. And I'm really excited to see kind of where they go with that.
Oh, that's fantastic. Those people sound great. We'll definitely reach out to them. And it is exciting. I agree too. It's the future, what's up and coming. So I love it. We'll definitely reach out. And Dr. Joelle Fenger, thank you so much for being on our show today. It was such a great conversation. Love learning so much about what you guys are doing and just can't thank you enough for sharing with us today.
Well, thank you. I'm so grateful for the opportunity to speak with you and get all this messaging out to the listening community. So really appreciate what you're doing, and I really hope that it continues to grow.
Well, that's it for this episode of the Veterinary Cancer Pioneers Podcast. If you enjoyed this episode and gained valuable insight, we would be so grateful if you could share our podcast with your friends and colleagues. And it would be even more wonderful if you want to give us a 5-star rating, positive review, or any kind of feedback on Apple Podcasts or wherever you listen. The Veterinary Cancer Pioneers Podcast is presented to you by Impromed.